muscular portion of the heart, these are the one that they don't have much symptom, and lots of times they close spontaneously. About 40 to 50% they can close spontaneously. And in contrast, the one that actually located in membranous portion of the septum, and they're especially larger, this is the one that actually going to be symptomatic. You're going to see symptom early in child, especially in this case. So this is an example of the large membranous VSD. These are the ones that usually they don't close spontaneously, and these are the ones that can produce symptom. So remember how we're gonna actually evaluate these cases. When you have a VSD, what you have is you have a two-chamber, a different differential pressure. So here is a left ventricle and right ventricle. What you have is a left-right shunt, and this left-to-right shunt actually produce the symptom related to these VSDs. So you have these holosystolic murmur, and actually you can see this due to this shunt. So the problem is, where is this blood gonna go? This blood gonna go through the pulmonary, gonna go to the lung. So what's happened is right away, what you have increased pressure in the lung. Remember how you're gonna measure pressure. Pressure is equal to flow times resistance. So what happened is, first you put a lot of flow in the lung and pressure buildup goes up, okay? But and this is irreversible, until the resistance actually going up. So when the resistance goes up, is the time that you have an intimal fibrosis and permanent change in those vessels in the lung. On that situation, this becomes irreversible. So imagine when the pressure builds up and become irreversible, and actually it goes more than the left side, you have a change of these channels. So you have the direction of channel going to change, and from the left to right, going to go right to left. You're all familiar with this Eisenmenger complex. Be familiar with some of the complications you get with that. So cyanosis, because the oxygenated blood mixed with oxygenated. Think about paradoxical emboli. Think about some of the infection that goes to the systemic circulation, for example, can produce abscess in the brain. So that's actually important regarding this. So when we talk about this is what we talk about in the pulmonary. So when you see here, you first actually, when you have an increased flow, you're gonna start seeing hyperplasia of the smooth muscle. And this is irreversible. As soon as you start seeing the thickening of the entima with the fibrosis, actually, when you see these elastics actually showing, that's irreversible. When you get the irreversible, doesn't matter you fix that VSD, because it's already permanently damp. Those vessels in the lung that are narrow, if you even fix the VSD, it's still going to be a pressure actually affect the right side, and it's still patient going to have a problem. So you want to fix these before that permanent change happens, that irreversible change happens in the lung. So, and another thing about the VSD is the one that usually kind of smaller. Those are the one that, as I said, is closed and they are isolated. But there are larger ones. These are the ones that actually show up early in life. Those are actually 60–70% can have other, congenital abnormality associated with them. As a matter of fact, those larger ones that show up early in life, those are just 30% are isolated. So that's with the VSD. This is a little bit about the, our case actually, another thing in our case was important. Remember, the patient not only had a systolic murmur with the VSD, had a diastolic murmur. The reason the diastolic murmur is when you put the loss of fluid and lots of blood goes to the lung and come back to the left side, there are more blood passing through that mitral valve. So the reason for that diastolic murmur is really actually you push more blood through the mitral valve. And these are actually, they call it innocent murmur. So the valve is nothing wrong with the valve, but the fact that you push lots of more blood through the valve that produces that murmur over there. So this is an ASD.
You'd have a holosystolic and a diastolic murmur?
You have a holosystolic and you have a diastolic murmur. The diastolic murmur is because of you put the loss of fluid, the blood coming back, lots of blood coming back to the left side and pass through the mitral valve. And actually, if you read the case that this, says it's both diastolic and systolic murmur. This is an ASD. So ASD's problem is less because actually you're dealing with the less shunt and the pressure on both sides is in compared to ventricle is less. So there's again, it depends on the location. It's very important to be familiar with this. So most commonly location is the ostium secundum here, that usually central, usually run. And actually the ostium primum that actually is kind of lower, these are less common and rare. And when you see them, usually these are the ones that associated with other abnormalities, usually associated with the atrioventricular, defect or other abnormalities. See, for example, endocardial cushion defect. So this is a very rare situation. So you don't see both of them together. So that's kind of rare. In terms of the Eisenmenger and hypertension, you may see with them, but it's kind of less, common because of the pressure and amount of shunt. And these are lots of time are asymptomatic because of the, it's not much of the shunt actually happen through this. Just know about the location and know about the type. The last one is a PDA. You're all familiar with the PDA is needed during the intrauterine life for baby to survive. This is a way actually the oxygenated blood come back to the aorta and actually goes to the placenta through the umbilical cord vessels. So remember, as soon as the baby born, due to the due to the increased oxygen pressure and the decreased amount of those prostaglandin, this is actually functionally closed. Now, if the baby is preterm or there is a hypoxic situation, this may be a stay open that they call it patent ductus arteriosus. And remember, the same concept goes here. You're going to have the same left to right shunt. Again, this is the least problem in terms of the pulmonary hypertension and Eisenmenger compared to other two. And one thing is very important that sometimes actually you need to keep this open, especially when you're dealing with some of those cyanotic heart disease in the last case. Actually, this is the only way you can get some blood to the lung. So when there is another congenital abnormality, sometimes this is the only way actually for the surviving baby, because this is the only way that actually you can get the blood to the lung. Actually, we're going to talk about it in the tetralogy of follow. So if you want to keep it open, you're going to give the prostaglandin. If you want to keep it, close it, you're going to give them endomethacin. So also remember, usually it takes a few months to completely close, so it's usually right away closed in a few days as a functional. The last case talk about the cyanotic heart disease. This is the tetralogy of follow. So remember all four components. The most important component is the determinant for the symptom is this, which is a pulmonary stenosis. Usually is very, very severe. And sometimes actually can be it's completely athletic. Then another component is a VSD. You have this large VSD. Then you have a hypertrophy of the right ventricle, and that makes sense because pushing a lot of blood, so you have this right to left shunt. And what you have is this aorta that actually sitting at the top of these VSD, we call it overriding. So remember, the reason you have these right to left shunt, if you think about it, for example, for VSD, before you just isolated VSD, you have the left to right shunt because the pressure was higher in this side. But now you have another resistance. You have these stenosis in pulmonary, and that's actually make the pressure higher in the right side. That's the reason you have the right to left shunt. One of the important points is if for some reason your pulmonary stenosis is not that severe, about 5% of people with tetralogy of Fallot have a pulmonary stenosis that is mild. In that situation, they are not even cyanotic. They are actually pink, and what they have is they have something exactly like an isolated VSD. So the reason you have all of these symptoms with the right to left shunt and all cyanotic heart disease is really this severe stenosis. Remember, the only way this blood actually get oxygenated is through the PDA. So this is a situation that you want to keep this PDA open. Because remember, the blood coming back to the right side goes to the left and then actually goes through the aorta. So really doesn't go to the pulmonary because of these severe stenosis. The only way it goes to the pulmonary through the retrograde is PDA. So keeping the PDA open is very important in tetralogy of Fallot. As a matter of fact, one of the procedures they do, they make an additional shunt to increase that, and actually after that, after some time, they can do complete correction Another one that is very important in terms of keeping the PDA open is this transposition of brake vessels. You can see, you can appreciate here, you have an aorta actually here, which is anterior and coming out from the right ventricle, and you have a pulmonary coming out from the left ventricle, and you can see if you didn't have any communication in terms of PDA, or even they have the open atrial septal defect, you can actually have you will have a two separate system, so it's not communicating. But the only way you get some blood to the lung and some communication through the PDA or ASD, actually atrial septal defect, and keep these babies alive. The last is the coarctation. Remember, there is a two type of coarctation. One, they call it infantile. Infantile coarctation is the one that is usually severe, usually symptomatic early in the life. What you have the arc of aorta, there is a hypoplasia, so the whole area actually is very, very narrow, okay? So that produces severe obstruction, so it's very hard to actually push any blood through that area of the hypoplasia. So the only way blood can go to the lower extremities actually is through the PDA. So in infantile type, what you have is the oxygenated blood from pulmonary artery goes to the distal aorta. So what you have in the infantile type of partition of aorta, you have these differential cyanosis in lower extremity. The one they ask you lots of time question is adult type. Adult type, you know, the obstruction usually kind of ridge-like in folding, and usually the PDA is already closed, so it's usually located just near that closed, you know, PDA. And what you have is, because of that obstruction, you have a hypertension in upper extremity, and you have a low pulses, low pressure, and weak pulses in lower extremity. And be familiar that usually lots of time there's other diseases associated with the partition of aorta, including bicuspid valve or Turner is important that associated with this. Also remember that because of all of these collateral between the before area of the obstruction and after obstruction, you can have all these notch in the ribs because of these intercostal arteries, which is tortuous and very, very large. I think that's it. So this is actually showing this area of the thickening of the wall and narrowing of the lumen that we saw grossly in the previous picture. Question? Done. Amazing.